A very good evening, dear friends. I here on behalf of Indian Society of Critical Care Medicine. We again welcome you for this another fantastic episode of Vodcast. And I invite Dr. Srishti Jain, an eminent critical care physician from the city of Jaipur. Both of us will be today kind of knowing, not interviewing. Pardon me, it's not an interview, but we are going to learn many things from our eminent faculty, Dr. Banambar Ray sir. He is actually at present HOD Critical Care Medicine, some ultimate Medicare unit in Bhubaneswar, and he had been holding quite different posts, vast different posts from diverse backgrounds, including at Apollo Hospital. He had also, served as general manager medical services at Tata Steel, Jamshedpur, and most important thing, he has contributed in initiation of ICUs in AIMS, Tata Main Hospital, even in some Ultimate Hospital and Apollo hospitals. He had been a very active member of Indian Society of Critical Care Medicine and hosted various positions in important positions in Indian Society of Critical Care Medicine. So he is a teacher, he is a mentor, and you will see that he how much experience that he is having, especially in today's topic, which is cost effectiveness. Now everyone talks about sepsis, ventilator, this and that, but the day in day out a lateral phenomena that we witness is the cost, especially in our part of the globe. So he is experienced, I would say, enriched with how to control the cost and so on and so forth. So, sir, thank you for accepting our invitation. As far as this is very important topic, I would say, not only youngsters or kind of seniors or nothing, but any diverse, any medical field, I would say cost is most important whenever we prescribe to subscribe or any investigation or anything kind of cost is important as a base. So, sir, to start with, I would like to ask first question. There are different types of hospitals, the kind of infrastructure with costs. And we know critical care has originated from smaller hospitals, but it has grown up to corporate culture. So can you highlight that how infrastructure or type of the hospital would affect the cost?
Thank you, Ritesh. Thank you, Srishti, for giving me this opportunity to really talk to you on the matter of cost, which normally is not talked about, as I have seen in the last 50 years. Most of the time, very rarely I see that cost is being talked about. Quality now we have been talking about, but not certainly the cost factor. Right. Now, let me, to answer your question, let me try to tell you what all the hospitals are divided into. You have got various types of hospitals, and we must know. Hospital, it could be a corporate hospital which takes care of patients in nearly 70% of our patients in India. And then the 30% are actually, insofar as ICU is concerned, right? Critical care is delivered by almost 70% of the corporate hospitals. The 30% that are remaining are the public sector hospitals, and public sector means it is government concerned, right? And then there are the organized sector hospital, which I mean are the ones which are actually patronized by, say, take for example, railways. Take for example, Coal India. Take for example, the industrial sector, steel industry particularly. There are quite a few steel industries which have got excellent hospitals. In fact, I am a product of one of those hospitals. I can vouch for it. Tata Steel, I worked for 30 years, and I know that how these hospitals run, right? And there are trust hospitals. To tell you about the trust hospitals are the one which actually run on a no profit, no loss basis, right? Now, if you have, for example, 50 crores of rupees you spend in a year and you get 60 crores. If you get 60 crores at the end of the year, then 10 crores you have a so-called operating profit, and that operating profit never goes away anywhere. It remains within that fund, and the 10 crores you can spend for the development of the hospital. That's a trust hospital, to speak in one line. Corporate hospitals are completely out and out profit hospitals. And then government sector hospitals are the ones where government finances almost about, I would say 95% of the cost that is incurred by these hospitals. Another 5%, they may be earning a little bit, but that's not actually their target. Their target is, to provide hospital services to the common man, and then they bear the cost, right? And then comes the what you call hospitals, the organized sector that I talked about. Organized sector have allocated a particular fund for the whole year, and that fund has got to be borne by the organization the hospitals belong to. For example, I am from Tata Steel, and then Tata Steel would be spent in the hospital for whole year, and then Tata Steel will bear the cost. Suppose you generate a particular amount of money at the end of the year, that is deducted from the contribution of Tata Steel. So this means for any other hospital, Shell hospitals, you have many other hospitals. So that is the thing which hospital runs at the cost of the primary organization, and the hospital doesn't have to actually say that I am earning so much. Hospital only will say that I am being financed by the organization I work for, and the organization bears all the costs. So these are the types of hospitals that we have. Now, when you talked about the structure. Now I come to corporate hospitals pay every single pie for whatever they provide, including the building cost, including the equipment cost, including the staff cost, including the whatever day-to-day activities they actually would have to undertake. They will pay each and every pie from their own pocket. So they have got to actually realize it from the patient, because it's a profit hospital, and not only also the year, so that they can sustain and share. Government sector, since it provides 90 to 95% of the cost, infrastructure cost, land cost, the staffing cost, the equipment cost, everything is provided by the government. So therefore, even medicines also are provided by the government. So therefore, government spends to the knowledge of the general public. Government only listens, but nobody realizes, or at least few of us realize, that government also spends for the infrastructure, maintenance, and everything, and also government spends for the salaries, right? It comes to around 70 to 75% of the total cost minimum. Salaries, infrastructure, equipment maintenance, everything, which is taken, that government is spending after all. But only medicines, consumable costs, that is visible to us that government is spending, but the government spends many more things like that. Organized sector, you don't talk about. Trust hospitals also, they have to charge, and they have to somewhere factor in the cost of the building and everything. But that is over a period of time, it has gone by, and can add the depreciation cost of the buildings and equipment to their expenditure or to their profit, whatever you call it, right? So trust hospitals are a little cheaper. Corporate hospitals are completely cheap, in fact, and if they take non-employees other than their own employees, then they subsidize that. So the public is very happy. And corporate hospitals have to spend for everything. Is that what you talk about? But when you talk of structure, 2 or 3 things I would like to say. Insofar as ICU construction is concerned, that there are there are ICU just just move in ICU. But when you plan an ICU, certain things you must actually plan out. And that is what, like for example, your ICUs must be infection control infrastructure proof. What I mean about that is that you provide all the standard operating procedures and everything is fine, but certain structural changes you must factor in when you construct an ICU. The structural changes are you must have employees, the patients' families, they come to see their patients. You must make sure that they do the hand washing. So therefore, before they enter into the ICU, there must be a proviso for hand washing. That must be always there because that goes a long way in preventing infections, transmission from the patient's family members who come from outside to the patient. Number two, I have seen ICUs in India where you have only one door into the ICU. Through that, your dirty linen, your clean linen also go back and forth, which is not right, right? And there must be two doors, one in and one out, which unfortunately you do not have it in many ICUs.
No.
The other advantage of having two doors is that you could evacuate patients at the time of any fire emergency, and that is what is a convenient outlet for you to kind of very quickly evacuate the intensive care unit. Third thing, the dirty linen must go through another route. It must be through a corridor if you can have it, if you have space.
So yes, so creating this kind of infrastructure adds to cost, but this is necessity. This is basic.
It has to cost, but it is cost effective. It's a word which we must really understand what it means. Even if there is a what you call infrastructure cost, that will be realized when you have less infections. If you have less infections, it helps the organization, helps the patient, it helps the doctors, and you can actually reap the benefit throughout. Okay, so therefore, it is a cost which is a good cost. It is not a bad cost, right? Once you do it, you don't have to spend money on this year after year.
Again, yeah. So the lending cost is high, but it always repays over a period of time.
Over a period of time, absolutely.
Yes, Dr. Srishti.
Yes, sir. Hello, sir.
Hello.
Sir, I wanted to know again regarding the, philosophy of cost effectiveness. Sir, do you feel that cost effectiveness is more about planning and resource allocation or about clinical decision making?
Srishti, it's a good question you asked. In fact, cost effectiveness is a term which is generally not properly understood. For example, let me tell you, you say that if you have a cost spent, how effective it is, you have to have an outcome. That outcome also must be costed. In medical services, you do not cost the outcome. You do not evaluate from the time of cost. For example, if you are saying cost effective, you spend a cost, you find out in terms of mortality, morbidity, how much is the outcome. If your death is more for a particular less cost that you have spent, will you be able to cost it? You will not be able to cost it. Right. Similarly, if the complications are more, you will not be able to cost it. So one is you are spending money, the other one is you can't translate it into money, the outcome, right? So cost effectiveness is a very, very, I would say, bad word for the medical industry. However, having said this, if you spend some money, you always try to project it that by spending this money, this year I have saved so many lives. This year I have saved so many complications. This year my length of stay has come down. Hospital has gained so much of money, so much of revenue. If you say this, And I think the administrators have to understand that. In that, you will be able to explain that this is cost effective without having, money for money return. So that is precisely how we must understand in our practice what is cost effectiveness, right?
So
Is
that
that
is
is
very,
that
very
what did I
important.
answer you this?
True.
Yes, yes. So it is very, very important. It is not like any other thing like I and ROI, investment and return of investment. There are
True.
multiple lateral factors which sir said it's not money is equal to money, but money is equal to outcome itself. I mean, you cannot even equate with any kind of money. So that is very, very important as far as critically ill patients and ICU is concerned. Sir, let us go ahead and come to the manpower. Now, it is not like manpower in ICU should be just head count. There has to be trained manpower. I'm not talking about ongoing training that keeps on going. But when we want to hire a manpower, including not only nurses and doctors, but even class 4 workers, because they are also needed and they also need to be such a trainable people or already trained people because they are very important as far as infection control is concerned. So resources in terms of manpower, sir, how would you suggest how to make it cost effective?
This is also a very, very interesting aspect of management in intensive care unit. Manpower you cannot equalize. The moment you say that I will reduce the cost on manpower, trained manpower particularly, it will be reflected somewhere else. You will have more of
Yes.
complications, you will have more of morbidity, mortality I'm talking about, you will have more of length of stay, you will have, a very bad infection rate, and, cross infection rates will be very, very high. All your infection rates will be, CRBS high or ventilator associated pneumonia. I don't know how much it is. It is so varied in this country, and that will be certainly reflected. Manpower, whatever we have decided that this should be the manpower. 1:1 we practice for ventilated patients. Nurses wise, 1:2 for non-ventilated patients in the intensive care unit, or in the STU, you may go for one intensive care unit as well. Even if they are ventilated, you have not many people to replace the people who are absent or on leave. You go ahead and do that, but don't economize on man. But you should not have too many manpowers if it is not required. However, having said that, if one nurse is supposed to look after one patient, say for 8 hours, you must have a time motion study. Out of these 8 hours, how much time he or she is spending with the patient? Often you see that people will go into the computer section, or they will go to attend the infection control meeting. They will go to leave a patient in the ward for 1 hour. Somebody else will replace them who doesn't know anything about this patient. So I think these are the issues that you must do a time motion study. Out of 8 hours, 4 hours, suppose he has not been or she has not been there with the patient. What is his or her salary? And then 4 hours means half the salary is wasted. You can actually cost it that way. That this is what the cost that I have lost in this particular patient, even if he's posted with the patient, but he's half of there. So that is exactly how you kind of, you know, you evaluate the cost, the loss of the manpower. So
Mm.
whatever you get, you must be able to utilize that properly, right? But do not economize on the manpower. It never is a good cost. It is always a bad cost if you have to economize.
So fantastic, sir. Again, a very
Really
valuable,
insightful.
yes,
Yeah.
yes, insightful and valuable lesson that manpower is equal to cost on lending costs. Again, it gives you a name, fame, and as a byproduct, money. So don't equate directly money to money when we invest in manpower. Manpower is the base of any hospital,
Very true.
especially critically ill patients.
Yeah.
Yeah.
Yesterday, I was reading about a gaming company, Valve, and the CEO has said that only thing which is more important than breathing is recruitment. All I focus is on recruitment, and I sit on my desk and I chill on my holidays. But I take an interview of each and every person, small, big, in my institute.
Yeah, Dr.
Because an
Srishti.
organization is as good as the employees.
Yes. See,
Absolutely.
organization is made
I
up of
think do not ever think of economizing on manpower. If it is just about something, like for example, a consultant should see 15 patients, not more than that. If he sees more than 15 in a day, I'm certain in my last 51, 2 years of experience, there will be suboptimal care. Right. I know that people say that they thump their chest and say that I see 30 patients in a day or 35 patients in a day. And I can assure you that I still work, with only how many 10, 12 patients or 15 patients, not more than 15. And a whole day is spent on seeing those patients, right? I think that is the kind of, outcome that you get if your numbers are limited. If your numbers, unfortunately, the corporate hospitals today will be always breathing down your neck saying that, Dr. Saab, I think with this many consultants, you will be able to manage this many beds. I said, no, I will not be able to manage. You see, even then, they will still do what they want to do. But please do not compromise on this. Similarly, a resident can see 8 patients or 10 patients max. A registrar can see 12 patients. These are all guidelines standardized, right? And not such is, as I said, 1:1 ventilated, 1:2 non-ventilated in the ICU. In the SDU, you may be having 1:3. But beyond this, please do not compromise. So it is a good cost. It is not a bad cost. But make sure, as we said, that all of them are there. As much time that they can spend with the patient, so much the better. I have seen ICUs in the Western countries. 1:2 they see, but they have a computer. They don't have to move out of those two beds. All the time, 8 hours, they are there. And they will do the indenting and everything there in the other bedside. They will never go and sit in the central station. Right. I think that kind of a workforce utilization is our concern. We must do, but do not economize on the manpower.
Right.
Very true.
Yeah, Dr. Srishti, we can go ahead.
Yes, sir. Sir, moving away from the philosophy, let's discuss about the infrastructure and the equipment. So, sir, what's your opinion on the debate between basic functional infrastructure versus cutting edge technology in ICU?
Well, that is again a fantastic question, Srishti. I will let you understand one particular aspect of that. You have taken an equipment, but you have not been able to utilize. Take, for example, a extracorporeal membrane oxygenation.
Yes, sir.
During the COVID times, almost every hospital worth its value and public standing took extracorporeal membrane oxygenation. Tell me how many of those are in use today? Some of
Very
the hospitals, they are doing it, but they are all lying idle, right? If they are lying idle, what this cost relevant at the time when you took 6 extracorporeal membrane oxygenation, each one costing about 35 lakhs. Just imagine, right? So if you understand this question, you choose your equipment. Cutting edge equipment by all means you take, but you should be able to utilize it. The kind of emotional argument that we give, even if I have one patient in a year, but I save that patient, whether you save or not, we do not know. But if it is only one patient, it is better that you send your patient somewhere else where they are doing it regularly. In the city, you should, for example, extracorporeal membrane oxygenation. In the city, like you come from Guwahati, Guwahati mein whether it is worthwhile taking extracorporeal membrane oxygenation in all the hospitals, respectable hospitals in the city. I doubt it is. It is not. It is. COVID times you forget, but rest of the times, if you have one good hospital with extracorporeal membrane oxygenation in a month, even if it does 4 or 5, also is good enough, right? So what I'm trying to say is that don't, for the heck of it, take those cutting edge equipment. That is not cost effective. Okay, it will be staying idle, and if 1 year you did not use, by the time it is required to be used, you find that something or the other has gone wrong. And then you call your technologies and all that, find out why it happened and all that. It's not really worth it. I think we need to understand this. Did I
Right.
answer
So the
your
thing,
question?
Yes, sir, definitely. And you had touched upon the actual scenario which happened. Like after the second wave, people were like, "Oh wow, ECMO is the machine," and people procured it. And then you didn't have the manpower, the training, the kind of rest of the infrastructure, or hospital capable enough to get patients who would be paying that much. And then the equipments were all lying around. So that's very true, sir. Very relevant.
so that is important. Actually, we must evaluate, as sir, you rightly said, the type of patient, the optimal utilization of whatever technology is. So we need to, because again, cost is important in our part of the world. Even if patient deserves ECMO, but if the cost is too much, many times we are not able to offer. So that is the biggest gap, in spite of having equipment and keeping it idle. So we must rethink before, and it's again a cost to have that instrument is a cost. And especially in corporate hospitals, they keep on asking, sir, ECMO aise hi pada hai. So this is
Yeah, correct.
yeah, this is very important. Before we go ahead, we must think of whether I'll be able to utilize it optimally. Then and then we must invest. Sir, having said that, let's go ahead. In day-to-day practice in critical care, we know that the lot of things, especially pharmacy is concerned, we can save a cost in a variety of modes. Sir, what's your suggestions?
You're talking about pharmacy.
Drugs and consumables, yeah.
Absolutely. That is another area which is again something which you can really economize on those. Unlike in the manpower cost, uh, pharmacy cost could be drastically brought down. I will give you one example. If a Paris hospital took a what you call review of how many people working in the ICU know about the cost of each and every consumable. It was only in 6% cases people knew who were what was the cost of that particular consumable. It may be a drug, it may be an appliance, it may be anything, right? Only 6%, 94% did not know the cost. They were way beyond the actual cost, right? So if it is so, then obviously we are not interested in it. You go to a corporate hospital, these people know. I think corporate hospital, that particular city, corporate hospitals had a little more percentage of people knowing what is the cost because they are accountable directly to the patient. Even in our hospitals, corporate hospitals, many people would be knowing what is the cost of most of the consumables because they are accountable to the patient's family, right? You need to actually be economizing. How do you economize on the pharmacy cost? I will give you an example. In a hospital that I was working before, a patient will be on 4 or 5 antimicrobials easily for no rhyme or reason. Right from the emergency site, they will be giving 4 or 5 antibiotics, and there could be antifungal also. I have seen quite a few patients on 7 antimicrobials also. Why is it so? That's because they are not quite confident, right? they will suppose a patient of sepsis comes, and a patient of sepsis comes without sending the blood culture, urine culture. If it is to be sent urine culture more than 5%, that's what we practice. You have to send the urine culture, blood culture, X-ray test. If required, sometimes you may do an imaging CT scan also. You do that is fine, but make a diagnosis if you have got time. Unless the patient is in shock, you don't need to actually start antibiotics all at once. And you must get an evidence as to what is the organism. At least that you should do in the first 48 hours. And then afterwards, you must do the de-escalation. Tell me how many patients in the hospitals, corporate hospitals, they practice de-escalation. They don't. I think de-escalation must be practiced. Therefore, you can economize on the cost. You will see that we do it very closely. If it is a closed ICU, de-escalation you can practice very well. If it is an open ICU, well, you have anybody to guess. Anybody can come in and start antibiotics. So therefore, first, it has to be a closed ICU. If it is a closed ICU, it doesn't mean that you are not taking the help of the other senior, respective area consultants. You are taking it. If it is a neurosurgical situation, neurosurgeon has to come in, neurology has to come in, but still you can be a closed ICU because intensive care practice must be closed. If it is closed, you can do this. And if you do that, you will see that your pharmacy cost will come down. You will get better outcome because your length of stay will come down. Your patient will be better earlier. Your infections in the ICU will come down. You can actually administer your all your standard operating procedures very well. So therefore, you can economize on the cost, and you should be able to find the evidence. Scientifically, you do it, you will be able to economize on the cost. This must be done, in fact, and it should not be. First of all, it has to be a closed ICU, and then
Right.
you can implement your things. You will be able to do it.
Yes. So well said, sir. See, and many a times I, take up kind of a small session with, students. There are a lot of misuse and overuse drugs in ICU. And to name the commonest drugs, two drugs which are unnecessarily and irrationally utilized are oxygen and IV fluids. So, if you rationally use this, we are talking about antibiotic stewardship and so on and so forth. But each and every drug stewardship is necessary, like nebulizations, ondansetrons, PPIs. There are too many things that we can control as far as we do. It doesn't need to be a prescription of 10 drugs or 15 drugs. Higher the criticality, higher number of the drugs. That's what, many times we see. So yes, Dr. Srishti, we can go ahead with next question, sir.
Yes, sir. So that was a very interesting discussion on equipment, and then we discussed about consumables. So let's go to the other part, that how can we avoid over dependence on repeated lab investigations, repeated imaging, repeat CT, repeat MRI, repeat this and repeat that, yet still maintain safety in critical care.
So pathology and radiology.
Srishti, that is a very sensitive aspect of critical care management that you touched. If you are a closed ICU, you can do that. We don't do too many imaging. We don't do too many X-rays also. You don't need to do too many X-rays, right? And whatever you can do as a consultant in the intensive care unit, that will remain valid. Anybody coming in and asking for certain investigations. For example, when a patient, that it is pneumonia shock, and they would still like to do a procalcitonin. Procalcitonin, I don't know how much it costs in your hospital, but in my hospital it costs 6,000 plus, right? Now, why do you need procalcitonin to be done? I will not do it. I don't do it. Procalcitonin, sometimes we do when you are de-escalating. That again is not required to be done all the time for de-escalation. So we do not do. But people would ask for it. Never do it. Don't do too many imagings at the same time. Do not actually ask for too many investigations. It's not required in the intensive care unit. Whatever is required, do it, but you justify why you did it. Did you wanted procalcitonin to be done? It is negative, say 0.1, right? If it is 0.1, why do you have to give antibiotics? You don't have to give antibiotics. If you can economize on this, do your procalcitonin. I will agree still. But if you do zero point 0.1 procalcitonin and still you give meropenem, ticoplanin, and polymyxin, I think it doesn't make sense, right? So if it is a closed ICU, you can do it. If it is an open ICU, you can never do it.
True, sir.
So, yes, we completely agree, sir. By and large, uh, one procalcitonin is equal to many times 2 to 3 days of antibiotics. Even if patient, we need to go more and more clinically. Even if the uh, clinical dilemma is there, then and then there is some role of this kind of investigations. For de-escalation, clinical judgment is far superior than procalcitonin. There is no doubt about how can procalcitonin guide us that whether patient is getting better or not. Right, sir? Yeah, Dr. Srishti, please, anything?
Yeah, sir. Sir, another question is that what is the impact of all the government schemes that we have right now around Ayushman Bharat? In Rajasthan, we have RGHS and Chiranjeevi schemes, and other insurance schemes are there, like private insurance schemes. So how do you bring everything together, and how does it affect our practice? And are they really sustainable for the hospitals, the government schemes especially?
You must understand that when a government scheme is floated, it's not necessarily primarily aimed at satisfying the general public. It's only primarily aimed at getting some political mileage out of it, right? That is point number one. Having said that, you have government schemes which are actually helping a lot of these people who normally would not have ever ventured to come to a corporate hospitals. So I think that's the plus side of that government scheme. Now, when they come, you are given one too many restrictions in prescribing medicines, right? You cannot give Meronem because Meronem is costly. It used to be, now of course it has come down. You cannot give Albumin. In certain schemes you may be allowed that. So all that I'm trying to say that there are too many restrictions on the government schemes. But even then, I think it is say 5 lakhs or 10 lakhs they give it for 1 year for one person. I think this is a terrific privilege to people who otherwise would not have afforded anything to come to a corporate hospitals. There are restrictions. Maybe that we, grind our teeth too many times that ye nahi milta hai, wo nahi milta hai. But still, I would say that the government schemes are good schemes, I think, for most of the people. So we should actually not discourage this. We should actually take this because that is how quite a number of corporate hospitals are getting filled up because of it. Okay, so therefore, I think it gives a lot of profiteering prospects to the corporate hospitals. Government hospitals, they also are quite comfortable with it. Of course, they do not spend so much because their consumable cost is not so much so as to eat away all these government schemes. So I think they're fine. But the other hospitals like trust hospitals, they are also happy with it. The organized sector also are happy with it. So government schemes, I would say that it is at least something better than having nothing to cater to our hapless patients.
Right, sir. Correct.
So I think, sir, we are coming to an end of this. And one last question, which I had reserved actually, because we had done a lot of work as far as value engineering is concerned. So, sir, please explain the concept of value engineering as far as critical care is concerned.
Ritesh, that is a very good question that you asked for, which perhaps not many of us are quite introduced to this particular phrase. Value engineering is it is an industrial phrase. Okay, you have how can you really cut down the cost of manufacturing? Okay. It was replicated in the medical circles, perhaps for the first time in 1992 in our hospital, right? In Tata Men, that was 1992. And since then, we have been doing it quite a bit. Let me tell you how it works. It is like, suppose you have a pen, you want to buy a pen which will write very well in about, say, 5 rupees today. Okay. Or sometimes you get that pen also from the drug companies also free of cost. Okay. So it is absolutely free of cost, you get it. But if you want to buy a pen which has a computer in it, which has a watch in it, and which has a golden cap on it. So it would cost you few lakhs of rupees. Okay. But what is its core activity? Is writing. Okay. For writing, you require 5 rupees, but for additional advantages, you require lakhs and lakhs. Would you like to have it? If you have a lot of money to spare, you can do that. But what you need is its core value is writing. So for writing, you need 5 rupees. You buy that 5 rupees. It can be replicated in your hospital practices. Why you have to go? You want a Maruti car 800, which doesn't cost so much. Nowadays, you don't get it. You can go with the same speed, at the same time to a particular destination. You do not have to have a Rolls Royce to go to that particular distance. In fact, you'll always think that accident ho jayega to kya hoga. Rolls Royce will be too costly, but Maruti, you are not really worried about it. But if Maruti can reach you in 1 hour, Rolls Royce also can reach you in 1 hour. So that is the value, cost and worth. Worth is 5 rupees of a pen, but cost is 5 lakhs. Okay. So that is the difference between that. How we replicated this. In ICU, all of us are aware that when the oxygen cylinder, those days now, of course, is liquid oxygen everywhere. But when the oxygen manifold room is there, if you have got 10 pounds, then oxygen alarm will come. So what we did was, we brought it down to 4 pounds because it is next adjacent to our ICU cubicles. So we brought it down to 4 pounds. If you brought it down to 4 pounds, we saved lakhs and lakhs of rupees with a consumption of almost 70 to 80 cylinders in a week. We saved lakhs and lakhs of rupees. There was no accident. 4 pounds, still you have got a lot of time to go and check and change the cylinders. That is a kind of value engineering that we did. And there are a lot of things that you could actually do on value engineering. If you can spend one, hand care which costs you 7 rupees, you don't have to take a full-fledged glove which costs you 60 rupees. And these are all repeated use, and then you should be able to save a lot of money in this. That is precisely what we do. Even today, I do. I do not have to take two even hand cares. I take one hand care with my right hand, and with the suction, I hold it, and I do it. That the left hand holds the suction. It doesn't require a hand care to be worn to hold that thing. You can do it with even a Caltex glove as well, right? So all that I'm trying to say is this: that economize on this. If it is not useful, don't use it. If it is, you can manage with a hand care, don't take a full-fledged glove. That is exactly what I am meaning by value engineering.
Fantastic concept, sir. I would compare it with, our safety checklist in critical care and medicine has come from the aviation industry. I think the same concept of value engineering from the industry, we need to adapt that, how to make the cost most effective, minimal cost with the same purpose, rather than having that luxury feeling. Like it is like, iPhone versus any good average plus phone. That how many features that we use of iPhone except calling and text. I would say 99% people use only 10% or 5% of the whatever is available, because there is no need. So need-based evaluation is also equally necessary. So thank you, sir, for this explaining this wonderful concept of value engineering. Dr. Srishti, any other questions? Otherwise, we'll just wind up.
Yeah, I think we had a great session and a lot of insights, and that's very true. जो मम्मी कहती है ना कि कुछ चीजें बाल सफेद करके ही सीखोगे. So that's how it is, sir. We learn from your wisdom and the timeless wisdom, which we cannot acquire from any textbook, but only time brings it to us. Thank you so much, sir. We had a great session.
Thank you, Srishti, and thank you, Ritesh. I think it has been a wonderful exchange of
Yes, yes.
thoughts. Something
Thank
we
you.
may have germinated few ideas in the minds of people as well.
Definitely, sir. Definitely.
Very,
It's a
very,
concept which we
Very
need to cultivate and propagate, sir.
very true.
So thank you once again, Dr. Srishti, my co-interviewer, and our eminent faculty, Dr. Banambar Ray, sir, for accepting the invitation in relatively short notice. Immediately, he never says no. I know him. So, and I thank Indian Society of Critical Care Medicine, our president, current president, Dr. Srinivas, Dr. Sachin Gupta, and most important, Dr. Ranveer Tyagi, who is organizing this kind of wonderful small sessions in multiple ways. So see you, friends. Have a very good evening, and see you in the next podcast, which will be this kind of interesting topic, not only clinical things. And we are publishing it first Friday of every month. So stay
Yes.
tuned. Keep checking on your emails. You will be getting the links and details every now and then. Thank you very much once
Thank you
again.
so much, everyone. A very good evening. Have a great evening. Thank you.
Thank you, sir. Thank you, sir.